Hello, everyone. So I think we'll just start with the introduction. I'm Dr. Grania Brigden. I'm the director of the TB department at the Union, and I'd like to welcome everybody to today's webinar, Scaling Up TPT Among Children and Adolescents, including children living with HIV and child contacts. This webinar has been organised by the Union Sub-Saharan African Child and Adolescent TB Centre of Excellence in collaboration with the Division of Global HIV and TB of the Centres for Disease Control and Prevention, CDC. It is clear that we cannot achieve the NTB targets without addressing TB prevention, and that children and adolescents are an important at-risk group. The recent WHO call to action on TB prevention highlighted that to reach the UN high-level meeting targets by 2022, it will require a massive scale-up of efforts and larger investments. The Union and CDC support this call to action and the actions needed to achieve this scale-up. So, without further ado, I would first like to welcome all the representatives from the Centre of Excellence member countries who are on today's call, as well as the advisory committee members of the Centre of Excellence. Before we get started on today's webinar, I will just go over a few housekeeping tips. So you may have joined the webinar using your computer speaker system by default. However, if you would prefer to join over the phone, just select phone call in the audio pane and the dial-in information will be shown. Please ensure that you are on mute during the presentations and when you are not speaking. There will be plenty of opportunity for questions at the end of the presentations, and we will be saving all questions until the end. You will also have an opportunity to submit text questions to today's presenters by typing your questions in the chat panel. You may send in your questions at any time during today's webinar, and we will collect them and address them during the Q&A session at the end of today's presentations. For the Q&A session, we will open the floor to allow discussion on the points raised by today's speaker, as well as to share your experiences and perspectives on TPT in children and adolescents. So it is my pleasure to introduce you to today's chair people, Dr. Rita Lolo and Dr. Kevin Zimba. Dr. Rita Lolo is a senior advisor at the Union and has worked in TB, HIV, and overall health systems and project management for 30 years in Zimbabwe and other sub-Saharan African countries. She is a strong proponent of patient-centered, decentralized, and integrated services for persons living with TB and comorbidities. Dr. Kevin Zimba is a consultant pediatrician at Matero First Level Hospital in Lusaka and an honorary lecturer in the School of Medicine of the University of Zambia. He currently serves as the pediatric HIV TB coordinator for Lusaka province and the childhood TB focal point for the NTLP. We welcome you both and thank you for chairing today's webinar. Rita.
Thank you very much, Grania. And once more, welcome to all our distinguished speakers and participants from across the region. TB preventive treatment, TPT, has long been recommended, but remains still inadequately implemented. The global coverage for TPT still remains low. For example, in 2019, it's estimated that approximately 450,000 child contacts of the age 5 years and below, that is only 33% of the approximately 1.3 million children estimated to be eligible for TPT, were started on TPT. And we are equally underperforming regarding children living with HIV. We are not able to start them on TPT at the numbers that we would like to see. In 2020, colleagues, as you know, the WHO published consolidated guidelines on TB, and its first module is on TB prevention. There is also an accompanying operational handbook. These guidelines affirm the recommendation to screen for eligibility and offer TPT, especially among groups of people who are at particular risk. These include young children, adults, and children living with HIV, and household contacts of all ages, without forgetting adolescents. However, countries will need support and guidance to adopt, implement, and scale up this updated guidance and achieve the UN high-level meeting targets. So, colleagues, in today's webinar, we will review the current WHO guidance on TPT for children and adolescents, focusing on what is new and share best practices that effectively contributed to programmatic TPT responses for implementing and scaling up TPT among children and adolescents, including children living with HIV and child TB contacts. But before we move to the presentations, I would like to go over to my colleague, Dr. Kevin Zimba, to make a few opening remarks from Lusaka, and then he will proceed to introduce the first speaker. Over to you, Kevin.
Thank you, Rita. Thank you, Grania, and thank you to all participants on the call and members of the CEO, the Center of Excellence. I'm Dr. Zimba. In today's session, or the webinar we're going to have, we'll have the WHO share their 2020 guidance on TB preventive treatment, focusing on the child and adolescent TB prevention. We'll then next hear from our CEO member country representative, that is Tanzania, who will share their country's experience and best practices to overcome challenges in implementing and scaling up TB prevention therapy among children and adolescents, including children living with HIV and childhood contacts in routine program settings. Unfortunately, the representative from Eswatini is unable to join us today. So that presentation was supposed to have from Eswatini will be instead replaced by Dr. Steve Graham and Dr. Maureen, who will speak to us about the new EGPAF stroke union training tools that have recently been launched. I think a link will be shared as we go on with the presentation. After the presentations, we'll have a question and answer session and share experiences and perspectives from all Center of Excellence member countries and the advisory committee members joining us today. I look forward to hearing your experiences and of implementing the TB prevention services in children and adolescents in our various countries that are participating in this call. Our first speaker will be Annie Make-Brands. Annie Make works as a technical advisor for the WHO Global TB Program and is responsible for developing strategies and recommendations related to the prevention, diagnosis, and management of TB in children and adolescents and their effective dissemination. She also enables scale-up of activities towards ending TB in children and adolescents in line with the targets as included in the political declaration of the UN General Assembly for high-level meeting that was on TB. Prior to that, she was working with the former WHO Tobacco-Free Initiative, facilitating the development of the WHO framework connection on tobacco control, and with the former WHO Family and Reproductive Health Cluster on mainstream gender. Dr. Annie Make-Brands will present on the 2020 WHO guidance on TB preventive therapy. Rita, over to you.
I think it's rather over to Dr. Anne Mike. I think we are ready for your presentation now. Thank you.
Thank you so much, Dr. Rita and Dr. Kevin, for the nice introduction. I just want to highlight to all that I'm not a medical doctor, nor do I have a PhD. So I have an MPH, and I'm very happy to present today on behalf of the WHO Global TB Program, and want to thank the Union and CDC for this opportunity. Next slide, please. So in my presentation, I will touch upon the burden of TB in children and adolescents, in particular related to TB infection, the UN high-level meeting target related to TB prevention, as well as how the roadmap towards ending TB in children and adolescents refers to key actions on prevention. Then I'll quickly go over the current prevention gap. So that
No hei, siellä on kauheita tapahtumassa. Juliana.
Sorry. The current prevention gap, progress against these high-level meeting targets, and the impact of COVID-19, as well as the joint call to action that was recently launched by WHO and partners. I will then go into the current WHO recommendations related to the prevention of tuberculosis, the POSI budgeting tools that are around that can help countries plan for the scale up of contact investigation and TB preventive treatment. And I'll conclude with some words on the current ongoing work on the 2021 consolidated guidance and operational handbook on the management of TB in children and adolescents. Next slide, please. So in 2014, Pete Dodd and colleagues estimated that every year about 7.5 million children are infected with tuberculosis. They also estimated in 2016 that about 67 million children are under 15 are living with TB infection and are therefore at risk of developing TB disease in the future. Children infected with TB are neither sick nor contagious, but they are at a greater risk of developing TB disease, especially those with a weakened immunity. Although TB is a preventable disease, the estimated incidence of TB in children under 15 years has increased in 2019 to almost 1.2 million children, including nearly 30,000 children with drug-resistant TB. Mortality has increased to 230,000 children per year, including 36,000 deaths among children who were living with HIV. Children that died of TB were often young and never accessed treatment. Next slide, please. So offering TB preventive treatment to persons at high risk of TB is part of Pillar 1 of the WHO anti-TB strategy. Contact investigation aims to identify these people and evaluate if they need treatment for TB disease or TB preventive treatment. Offering them timely TB preventive treatment after exclusion of TB disease will not only protect them from becoming sick, it will also cut down on the risk of transmission in the community. To accelerate progress towards achieving targets included in the anti-TB strategy, member states have agreed in September 2018 on targets both for TB case detection and TB prevention to be reached in the period 2018-2022, with a second UN high-level meeting planned for September 2023. So as you are probably very familiar, the high-level target related to TB prevention is that at least 30 million people are reached with TB prevention services during the period 2018-2022, including 4 million children under 5 years of age, 20 million other household contacts, so also including children above 5 years of age, and 6 million people living with HIV, also including children. Next slide, please. Then the roadmap that was developed in 2018 by the core members of the Child and Adolescent TB Working Group also includes key actions related to TB prevention. And they call for scaling up contact investigation and provision of TB preventive treatment. Next slide, please. Despite all of this, and also as highlighted by Rita at the beginning of the webinar, in 2019, 2/3 over the 1.3 million eligible contacts under 5 years did not access TB preventive treatment. Reasons for this policy practice gap is that contact investigation is not routinely conducted or restrictive, meaning done in a passive way. There's limited access to TB preventive treatment, in particular to shorter regimens and child-friendly formulations. There's a lack of capacity among healthcare workers to distinguish infection from disease and concerns about providing monotreatment in case of TB disease. There's a lack of understanding and resistance from parents and caregivers to provide TB preventive treatment to healthy children. And that all of that is also coupled with still a suboptimal coverage of BCG vaccination. Next slide, please. And please click once more. So in terms of progress against the high-level targets that we have, and these are data that came into WHO over 2018 and 2019, so 2 out of the 5 years, and these data have been included in the Global TB Report 2020. In terms of prevention, only 20% of the 2022 target of 4 million people has been reached. Sorry, of the 4 million people who should be placed on TB preventive treatment. And in terms of the under 5s, only about 782,952 contacts were reported to having received TB preventive treatment in 2018 and 19 together. If you look at the over 5 years, it's less than 1% of the 2022 target. This may be because it's a recent recommendation, but still we're really doing badly globally on placing people above 5 years, household contacts above 5 years on TB preventive treatment. Where we are doing well is in terms of providing TB preventive treatment to people living with HIV. However, unfortunately, we have no idea how many children living with HIV were receiving TPT in 2018 and 2019. And we're making an attempt to refine data collection for the upcoming Global TB report and onwards. But it's still hard to get such data from countries that do not have electronic recording and reporting systems. So next slide, please. And then the COVID-19 pandemic came in, and based on reports from our regional and country office, as well as the partners united in the Child and Adolescent TB Working Group, we learned about the delays in TB diagnosis and treatment in adults, adolescents, and children, as well as the interruption of household contact investigation and provision of TB preventive treatment. And all of those are leading to increased household exposure to TB. And then this coupled with an increase in job loss, reduced household income, increased poverty, food insecurity and malnutrition, missed health checks and vaccinations, including the BCG vaccinations, and interruption of education and missing out on meals provided in schools. All of this is leading to an increased vulnerability to TB and other diseases. Next slide, please. But as recently included in the screening guidelines, children who are in contact with a known patients with infectious TB should be evaluated for active disease. And if they are well, they should be offered TB preventive treatment to prevent progression from TB infection to TB disease. And we think that there are many opportunities for national TB programs and partners to simultaneously respond to the COVID-19 pandemic and advance prevention. the countries should maintain BCG vaccination at birth or as soon as possible thereafter, enhance infection control in institutions, including in health facilities and schools. They should combine contact investigation for COVID-19 and TB, and they should fast track the rollout of TB preventive treatment with shorter regimens that have the potential to facilitate adherence, and use e-learning for health worker capacity building, and deliver medicines at home in the community, and use as much as possible the digital technologies for adherence and patient support. Next slide, please. So as you saw earlier during the webinar, behind Grania, with only 18 months left to reach the 30 million people of all ages with TB preventive treatment, as committed by the heads of state in September 2018, there is a great urgency to step up action. And therefore, on the 15th of June, WHO and partners launched the second call to action, calling on governments and other stakeholders to keep the promises they made and accelerate coverage of TB preventive treatment for contacts of people with TB and others in need. And on the screen, I have copied the link on which you can find this second call to action. Next slide, please. And then I would like to go into the main part of the presentation, which is about the current WHO recommendations related to TB prevention. And there are basically three components to that. One is the recommendation on infection control. Then there is an updated position paper on BCG vaccination. And then, of course, last year we launched updated guidelines and an operational handbook on TB preventive treatment. So in terms of BCG vaccination, it's now, it is always, as in the earlier versions of the position paper, it's recommended at birth or as soon as possible thereafter in all high TB and or leprosy burden settings. The position paper reiterates that children who are HIV infected should not receive BCG vaccination unless they are on ART, clinically well, and immunologically stable. There's also refined recommendations in there on asymptomatic neonates born to mothers with bacteriologically confirmed pulmonary TB. They should receive TB preventive treatment after exclusion of disease. And if the infant remains asymptomatic on follow-up without immunological evidence of TB and is HIV negative, BCG vaccination should be provided using a normal infant dose after completion of TB preventive treatment. I'm going into the other, or I'm not going into detail into the infection prevention and control guidelines that were launched in 2019, but they can be found on the link included in the presentation. And with respect to the guidelines on TB preventive treatment, these will be covered in the next couple of slides. Next slide, please. So WHO now recommends new shorter options for TB preventive treatment in addition to the widely used 6 months of daily isoniazid with better prospects for adherence. Shorter TB preventive treatment options that are now recommended range from a 1 month daily regimen of rifampicin plus isoniazid to 3 months weekly rifampicin plus isoniazid and 3 months daily rifampicin plus isoniazid, or 4 months of daily rifampicin alone. The regimens for which WHO has made strong recommendations are indicated in this slide in bold. The choice depends on availability of appropriate formulations and on considerations for age, safety, drug-drug interactions, and adherence. There are currently age limits for 3HP, which can only be provided to children above 2 years, and 1HP, which can only be given to children above 13 years. pregnancy does not disqualify women living with HIV from receiving IPT. To test for TB infection, a tuberculin skin test or interferon gamma release assay, the IGRA, can be used, but availability of these tests should not become a barrier to scale up access to TB preventive treatment. And testing for TB infection is not required before starting TB preventive treatment in people living with HIV and in children under 5 years who are contacts of people with active TB. Chest radiography can play an important role in ruling out TB disease and increase confidence in providing TB preventive treatment. Next slide, please. So which regimen to use in which situation? So the 3 months of daily rifampicin and isoniazid, 3RH, is a very suitable regimen for treatment of TB infection for children, for younger children, as many TB high burden countries now have the new child-friendly FDCs widely available. The 3 months of daily rifampicin isoniazid TB preventive treatment uses the same FDC as for the continuation phase of TB treatment. And older children can use the adult RH FDC. 3HP is a very promising future regimen, including for children living with HIV, but currently no FDC or child-friendly formulations are commercially available yet. The 6 months of daily isoniazid is still the regimen of choice in children living with HIV on dolutegravir, lopinavir, ritonavir, and nevirapine, and also for HIV-exposed infants on nevirapine prophylaxis, as rifampicin has a lot of drug-drug interactions with the ARVs. The current use of the 100 milligram dispersible isoniazid tablet, available through the Stop TB Partnership Global Drug Facility, would facilitate adherence and therefore is recommended in younger children. Next slide, please. Thank you. In selected high-risk household contexts of patients with multi-drug resistant TB, preventive treatment may be considered based on individualized risk assessment and a sound clinical justification. This is a conditional recommendation based on very low certainty in the estimate of effect. The TB preventive drug choice are the later generation fluoroquinolones, the levofloxacin or moxifloxacin, unless the source case is resistant to these drugs. There are some concerns regarding retardation of cartilage development in children, but this has not been demonstrated in humans. 3 studies listed at the bottom of this slide, the TB CHAMP, Phoenix, and VQueen studies, are currently ongoing, and results are awaited to inform further recommendations about TB preventive treatment for contacts of MDR patients, including child contacts. Next slide, please. So at the end of 2019, the Pediatric TB Operational and Sustainability Expertise Exchange Task Force, under the core team of the Child and Adolescent TB Working Group, which is a group of technical partners led by ECPATH, collaborated to develop a budgeting tool to assist countries in costing out high priority interventions for children. And these budgeting tools include household contact investigation and provision of TB preventive treatment. So these tools should facilitate the development of adequate budgets to be included in national strategic plans as well as in funding applications. So the tools are available on the links indicated in this slide. They are also available on the website pages of the Child and Adolescent TB Working Group, which are part of the Stop TB Partnership website. Next slide, please. So this is my final slide. I wanted to give you a little bit of an update on what we are currently working on. WHO convened a guideline development group meeting on the management of child and adolescent TB, and it took place in 12 sessions of 3 hours from 31st May to 17th of June. And the 25 GDG members from around the world were invited to review new evidence on TB diagnostic approaches, the use of gastric aspirate and stool on the expert ultra assay, and evidence related to treatment decision algorithms. They were also invited to review treatment shortening for children and adolescents with non-severe TB, so to consider the results of the SHINE trial. They were invited to look at the evidence on the treatment of rifampicin-resistant, multi-drug-resistant TB, in particular the use of bedaquiline in children under 6 years of age, and the use of the laminate in children under 3 years of age. They looked at alternative treatment options for pediatric TB meningitis, and they looked at the evidence collected regarding models of care, meaning decentralization of services for children, adolescents, and families closer to where people live, and integration of services and family-centered approaches. WHO has drafted a rapid communication summarizing the evidence that has been reviewed by the experts and indicating the next steps ahead of us. We aim to release this rapid communication before the end of July, and we aim to release the final guidelines together with an operational handbook with implementation guidance towards the end of the year. And these documents will consolidate existing recommendations, so including the recommendations that we have on TB prevention, with the new recommendations that are currently under review. And then next year, we hope to work closely with partners to help countries take up the new guidelines and to build capacity. And we will also work on training materials next year that are going to be included on the WHO Global TB Program knowledge platform, either in WHO Open TB or in our Open Access, or in the WHO Academy, depending on whether the Academy site is already up and running. And we look forward to work closely with partners on those materials. So thank you very much for your attention. Of course, this is not my work. This is a work of a group of colleagues together with many members of the Child and Adolescent TB Working Group, and the people who are focal points for this area, either on the management of TB in children and adolescents or on TB prevention in general, are listed on this slide. So thank you very much for your attention. And if you want to reach me, my email is at the bottom of this slide. Thank you so much.
Thank you very much, Annemieke, for your very comprehensive presentation, as well as for sharing an update about the guideline development progress so far. Colleagues, may I also remind you that you can enter questions to Annemieke and our second presenter, Dr. Mataka, anytime during this webinar. Please use the chat function that you can see probably at the bottom bar of the menu for the Zoom call. We will now move on, and it's my great pleasure to introduce to you Dr. Hassan Mataka. Dr. Mataka is a medical specialist, and he serves as the National Childhood and Adolescent TB Coordinator at the National TB and Leprosy Program in Tanzania, where the program, as in most other countries, is with the Ministry of Health, Community Development, Gender, Elderly, and Children. Currently, he serves as a technical working group member of childhood tuberculosis, tuberculosis in the mining sector, as well as the monitoring and evaluation group at the national level. In addition, Dr. Mataka served as a MNE, Monitoring and Evaluation Manager, to the Global Fund at the Ministry of Finance from 2014 to 2018. And before that, he worked as a district medical officer in 2 districts in Tanzania, that is districts of Mbulu and Ukwere. That was between 2010 and 2013. Dr. Mataka will be presenting today on Tanzania's country-level experience and best practices in implementing and scaling up TPT among children and adolescents. And for short, the title is, as you can see it on the slide. So Dr. Mataka, we are very excited to welcome you. It's over to you. Thank you.
Thank you so much. I'll take you through the scaling up TPT among children and adolescents, including child with HIV and child contact in Tanzania. Next slide, please. My presentation will have an overview of the TPT implementation in Tanzania, trend of the implementation, COVID-19 situation, issues on the TPT, and the planned efforts. Next. First of all, in Tanzania, our drug of choice is isoniazid for 6 months. And for the children less than 5 years, household contact for bacteriological confirmed TB cases. For the record in the WHO report 2020, we are around 39%, and our plan is to scale up. And then for people living with HIV, it was 6%, but up to March 2021, we are at the 72%. Next. This is a trend for under 5 who started the IPT in Tanzania since 2015. And as you see, the trend is that there is an increased cases, the increased uptake for IPT for under 5s as we move forward. So by 2020, we have 9,000 children who received the IPT, started IPT. Next. TPT coverage among HIV as of March was 72%. This was based on the regional analysis, which shows about 15 regions which have lower than 80% of the TPT. So we are still on push for increasing the uptake up to 80% and above. Next. For the child survivor from the TB, as we know, actually there is a need of the effective prevention of the transmission in the households. But as you know, the diagnosis of TB is challenging, and the overwhelming of the COVID-19, families are still reluctant to bring an unwell child to the hospitals. So they are discouraged for using health facilities at some times, and the provision of TPT in the community, which require resources to contact, to trace, screen, eventually implement TPT is limited. Next. So the issues in our country, first of all, is still using 6 months isoniazid, despite of the latest WHO recommendations, including 3HP and 3RH. And we know that 6 months is a long time for children, and for the parents to take their children to take medicine for 6 months is still a challenging issue. Then we have health workers who have a limited knowledge on the importance of provision of TPT and the proper administering. And then the other issue with the erratic key availability, I think this is due to the COVID situation in the global. So it is a bit challenging even in our country. Next. What are the planned efforts for TPT? We are continuing with the capacity building and mentorship to health workers for them to know the importance of TPT and the proper administering. And then through National TB and Rape Loss Policy Brief, we continue sharing the gap with the higher level, including provision of the local evidence and the research findings in country, so that they can understand why we are thinking of going from more months of 6 months to shorter regimens as advocated by WHO. We continue with the contact tracing of household contacts, of bacteriological contacts, and this is a resource need situation. So we are still doing for those who are bacteriologically contact, and they're planning to conduct a mop-up campaign among those eligible for PLHIV in each event data INH in the country by new stock analysis and the quantification. Next. Thank you so much. That are the few I can share with you today. Thank you.
So thank you, Hassan. The people on the network, please remember that you can enter questions for any of our two previous speakers and the ones that are just about to, the ones that are about to come. Thank you for that presentation, and I see great efforts that you're trying to. You see the great efforts that you're trying to achieve in scaling up TPT services in your country. We will now hear from Steve Graham and Dr. Maureen about the new EGPAF union training tools that have recently been launched, and they are now available to all COE members through a link that will be shared on the slides. Thank you. Over to you.
Maureen, hi, it's Steve. Thanks very much for this opportunity. I was wondering whether Maureen would like to start. She certainly did most of the work for this. So, Maureen, are you happy to speak?
Yes.
And I can support? Yeah, thank you.
Yes, yes, thank you very much, and greetings to you all. I wish to take this opportunity to first of all thank the union for providing this platform to enable countries share their experiences. We do know the challenges related to child and adolescent TB, and there's nothing greater than really tapping into country experiences, especially among high burden countries. So thank you very much. And then I take the opportunity once again to support, to appreciate EGPAF, particularly the CAP-TB project, for also providing an opportunity to have the child and adolescent TB training tools supported by the union to be updated. So I don't know, are you, Grania, are you going to click on the link? So the tools are available as slides. There is a participant manual, there is a facilitator's manual, there are sample questions, course evaluation. So these are generic documents that are built onto the guidance that is provided by WHO, and trying to have the information summarized so that countries can really use it as a template for developing or reviewing or updating their materials. So particularly, there are 9 modules that span across the care cascade for child and adolescent TB, right from identification of the child or adolescent towards screening, diagnosis, treatment, follow-up. There are concepts of TB, HIV, evaluation, and integration. So these particular training tools bring a new concept, relatively new, but we've been really encountering adolescent TB, but we have highlighted the unique issues of adolescents and how this can be integrated into the entire child and adolescent TB cascade. The other strong part about these materials, they are in a modular format. And we know that a modular format provides an opportunity to provide a targeted capacity building. Say if a particular health facility, hospital, or even at national level, regional, provincial level, depending on the NTP structure. So if there is a gap that has been identified across the care cascade, one can focus on a particular module to strengthen capacity. The other strength is that there are case studies that really, for each module, there are practical case studies that can be used to enhance the competences. I think one thing that is very critical for child TB diagnosis is confidence to make a clinical diagnosis. So we've included several case scenarios that facilitators can really tap into to adapt or adopt to their local setting and have the clinical skills really enhanced for the different stakeholders that are engaged in a child and adolescent TB management. So these materials really target the frontline health workers, program managers, providing child and adolescent TB. We propose a 3-day duration for this training, but again, depending on the context, the duration can be a sample schedule that can guide the facilitators or the training organizers to follow and quickly put their setting into context. I also wish to hand over to Steve to make any additional comments. Over.
Yeah, thanks very much, Maureen. Excellent coverage of the issues. This training built on previous work that we've done in developing WHO training tools around the time of the previous guidelines of 2014, and also union online training, which was developed some time ago. But importantly, I think that this training is informed by the most recent guidelines that we have. And the intention is to update them further once the 2021 or 2022 child and adolescent TB guidelines are published, which will be which Anamika referred to. I do think that they are stronger than previous training tools, particularly in the areas of diagnosis, prevention very much so, and also MDR-TB, I think definitely stronger than the previous tools that were there. And as Maureen said, I think it really probably the main focus has been to aim these for use by people at the front line, which is particularly primary and secondary level healthcare workers, primary healthcare district hospitals. People working, paediatricians working at the tertiary level, perhaps feel as though they know this content fairly well, but they may find this useful to adapt for their own teaching or training as well. So that's been the intention, and I think it's really comprehensive. So to be adapted for use in a range of different circumstances. Thank you.
So thank you very much, Steve and Maureen, for that presentation on the training tools that are available. Would like to now proceed to the question and answer segment. So would like to open the floor now for any questions that are available and discussions with our participants and the speakers. Just to make sure that all of us know how to go ahead, we need to raise our hands, and the raising hand function is found in the reactions. If you're using the computer, you can actually see on the bottom a button that says reactions. That's where you find the raise hand button. If you are not able to raise your hand, you can type your question in the chat box. We'll definitely go through the chat box and respond, read out your questions, and ask the presenters to respond to your questions. Any questions? There's a hand up from Hans and Nimek.
Thank you so much. Yeah, there were two questions in the chat. One about how long, when can TBT be given after TB treatment? So a person can take TB preventive treatment immediately after TB treatment if the exposure is confirmed. And there was also a question about duration of protection among people living with HIV. So this is, according to current evidence, approximately 5 to 15 years after TPT is provided. And about repeated TPT studies are still ongoing, and I understand there is some evidence emerging from brief TB trial. But I understand from my colleagues who are the focal points for prevention that this should be considered on a case-by-case basis once a new exposure is confirmed. So that's in response to the questions. And I also wanted to thank Brittany for her comment about data on TB preventive treatment to children living with HIV. That's good to know that these data are available, and I think we should link and see how these data can be used towards the global database. Thank you very much.
Okay, so thank you for that reaction. I think I would just also beg you to go through the first part where you talked about somebody who had just finished TB treatment. What is the guidance? I know we have different guidances from different countries.
Yeah, according to my colleagues, the focal point for prevention, it can be given immediately.
Okay, so thank you very much. And I asked that because I think we have different guidances. In my country, Zambia, we opted not to give TPT prevention therapy after somebody finishes TB treatment, unless they've been exposed to TB. Is a significant exposure to TB after finishing the treatment, then they're eligible to receive TPT. And we do repeat TPT every 3 years in our HIV-infected population. That is there. So there's some questions in the chat, I think, that was being asked about what was being used by Hassan in Tanzania for the TPT, the INH that they're using. I think Hassan responded that they're using 100 milligrams tablets. That's what they're using for children. And yes, they have a combination of rifampicin isoniazid to be used. I think countries like Zambia as well are using rifampicin isoniazid for the HIV and infected children for TPT. Any other comments or reactions? Please remember to type through, either raise your hand. There's a button which just says reaction, then you can raise your hand, or type your questions in the chat box.
Kevin, I see that we have a question from my country lady, Dr. Clarata Kwanzura, that is directed to Hassan. She is very appreciative of the outstanding coverage, TPT coverage in Tanzania of 80%. Well, the national average. Some areas are above that, some regions or provinces may be below that. And she would like to have further details on this. Clorata, do you want to pose your question, or shall I read it from the chat? Are you able to unmute yourself, please? Or Grania, do you need to unmute Dr. Kwanzora? If it doesn't work,
Hi.
There you are. Over to you.
Sorry, my network was breaking, so I wasn't aware that the request was for me to unmute myself. So I think I was just asking Dr. how they were calculating the coverage. We look around seeing in the region and in various areas in terms of TPT coverage. My question was whether they were calculating this coverage as a coverage of people who have ever received TPT. So from the time that the TPT program started in the country, or the 80% is calculated as a performance against target if they are targeting a particular number of people per year, whether that 80% is performance against that target. How they have managed to maintain those high numbers and reaching to 80%. There are a number of challenges for other countries to reach to that level. Thank you.
Thanks a lot, Clorata. Over to you, Hassan. Would you like to comment? Thank you.
Hello, thank you. We raised the TPT uptake despite of the COVID situation. Hello? Yes, actually we have invested much on the community health workers. So what we are doing is that we give them the PPEs, and then they, because they are living on the population where the TB is, so in the households where there is a smear positive, we use them for the most of the time to make sure they reach all the homes where we need them to be.
Hassan, we may be losing you.
I think that is one of the areas, even though it was up there, it seems to be more vigorous.
Dr. Hassan, you may have a little bit of a problem with connectivity. We keep on losing you. We hear the beginning of a sentence, and then we unfortunately lose you.
He's unfortunately dropped off the line. I think his connection's gone. He's not on the line.
I have a
There he is,
connection
he's back.
where I am. I think I will write down, then you can take it from the chat.
Thank you. And Brittany has proposed the same approach. Thank you for being flexible. Let's innovate so that we can keep the discussion and exchange of experiences going. And Hassan, my question to you regarding the data on TPT pertains to those areas, the regions or provinces in Tanzania that are performing below the national average. Are you able to break down the performance, TPT uptake, all the way down by district in a given geographical area or province, and then all the way to a facility level? Do you dissect data all that way in your country? Over. Kevin, have you seen any other questions in the chat?
There's no question. I can't see a new question in the chat.
Okay.
But there's just a comment from Isabel. I don't know, maybe should I like to comment? They've commented on opted to use one-time TPT course and is only repeated if a person becomes exposed in Mozambique. I think that's what is there. There's no other question.
Yeah, lovely idea. Let's hear from Isabel. What is your experience in Mozambique? If your connection allows you to share with us, please do feel free to unmute yourself.
Okay, so as we are waiting
still on the line, sorry.
Okay, as we're waiting, we can now try and hear from country representatives what the experiences has been, the biggest challenge that they are facing in implementing and tracing activities to identify children for TPT, and including treatment for TB. So can I try, since I'm chairing, can I start with Zambia?
Absolutely,
Okay.
Kevin. And if you don't mind also sharing what is the plan in your country about the use of the shorter regimes, like we heard from a number of speakers that 6 months of INH is still in use. That would be of very great interest, at least to me. Thank you.
All right. Okay. So I think for the National TB Epilepsy Program has actually done quite well implementing our TB preventive strategies. So we do have, I think, 3 HP in country. We do have rifampicin and isoniazid available to be used, and the isoniazid. We have the pediatric formulation for isoniazid and a lot of B6 in country to be used. So for the pediatric population, especially the ones that they are not living with HIV, we are agreeable and recommend that we can use a shorter regimen of 3 months using the rifampicin isoniazid. And then for the children that are eligible, according to this, we're using the similar WHO criteria that was presented by Rita on the 3 HP. We can use 3 HP, the 3 months regimen. And that's the weekly dosages that will be given, 12 doses. Then we're also using the isoniazid for 6 months. So the 3 HP, we've launched it in a few selected sites. Not all sites are doing it. We'll soon roll out to most of the sites in country to do that. Then what we've seen is that we had challenges initially with putting a lot of children living with HIV on INH. Then the reason mainly was that we didn't have B6. So it was either we had B6 or didn't have INH. So the last, I think, 4 months plus to almost 6 months, we've had good stocks of both INH and B6. So we've seen a very big increase in the number of patients that we're putting on TPT. For one of the major provinces in Zambia, like Lusaka, we have reached, I think, about 77% of our children being on TPT in most of our facilities in Lusaka district. The national picture may be a bit lower, but we've gone that. Then we also brought in the use of IGRA to help IGRA test the children in ruling out those that needed or didn't need to be on TPT, those that are TB infected. So that's been the experience. And of course, with COVID, we've had a few challenges, but I think we've been able to show sustained gains in the TB program, as has been exemplified with our data. As we noted, for Zambia, we managed to get 40,000 plus TB cases notified last year, which is 5,000 more than we normally do every year. And we're doing quite well. So for the people living with HIV and the children, we've made quite well. So any other country that is able to give us the next comment or any questions or reactions?
Yeah, hello.
Yes, please go ahead.
Yes, yeah, my name is Anthony, joining in from Ghana. Yes, I commend you for the great job doing. And I must admit, we are not doing too well in that area at all. But definitely, we are learning from each other as Africans and as countries. So I'm taking a lot of notes, and hopefully, I should be able to talk to the national program, and then we are able to strategize and get our TPT high as is expected. Thank you, and a good work. Thank you. Yeah.
Thank you very much, Anthony, and thanks for the comments from there. We have a question in the chat coming from Steve Graham asking whether use of B6 is necessary for IPT. So for Zambia, initially we were not giving B6, but then there was sort of communication with the older regime, especially for those living with HIV, that needed B6 to get that. So in our guidelines, we opted to make sure that everyone who's going to receive B6, INH, will receive B6 if they're living with HIV. So it's not necessary per se, but those who are living with HIV, we strongly recommend that they do receive B6 together with INH. That's what Zambia recommended in our guidelines. Okay.
Kevin,
any other comments?
While we wait for countries to comment, and we have got several COE founder member countries present. In addition to Zambia and Tanzania, we have got Mozambique, we have got Kenya, we have got Uganda, we have got Zimbabwe. But perhaps before we invite you in, I believe that Grania has come up with a poll on, is it on the shorter regimens? Yes, type of regimens that are in use. Could we all take a minute to respond to the poll, and then I will ask Grania to share the results. Thank you.
And in the meantime, if any countries want to, as well as complete the poll, share their experiences of the regimens they are using, and if they have transitioned from 6H to some of the shorter regimen, what their experience of that has been, that would be very helpful.
Thank you, Grania. Have we all responded to the poll? And Kevin and I also record the raised hands from Maureen and Steve. Thank you. May I ask you to be a little patient, and let's hear the poll results, unless it takes a moment for Grania to process them, and we can invite one of the member countries to comment. Who would like to come next? Here are the results. So I do not see how many of us participated in the poll, but those of us who did participate do report that we are still very much on 6 months of INH, 70%. However, the two shorter regimens consisting of 3 months of rifampicin and isoniazid, and 12 doses of isoniazid and rifampicin are climbing up at 30%. And in 20% of our countries, there could be a situation of mixture of regimens, especially if we have got ongoing TPT projects supported by partners. Thank you, colleagues, for participating in the poll. Now I hand over back to you, Kevin, to get the country experiences and country updates in regarding the questions that we have recently posed. Thank you.
Okay, thank you. I think let's allow Steve and Maureen to quickly go, then we can get the response from the member countries.
Yeah, thanks, Kevin. If I could just ask for some clarification around what indicators programs using for the implementation of preventive therapy. Is it coverage, uptake, completion, etc.? And is there wider use of registers So I'm not really sure who the question could be. It could be to any of the people working in any of those countries, but I'm just interested to get some clarification on what indicators are used and what monitoring and evaluation tools are used.
Thank you, Steve. Maureen, your question?
Yes, thank you very much. Mine is not a question. Maybe to just share Uganda's experience in TPT uptake, particularly for under 5. So for with HIV, we've made a steady positive trend, especially resulting from the increased community awareness. There's a lot of advocacy. There are targets, and there's also TPT surge. So these have contributed really to the positive trend, because we keep monitoring on a weekly basis for TPT uptake among people living with HIV, compared to the targets that set. And these targets have been set both at national and subnational level. For under 5, we have also included it in the TPT surge, though the trend is not as steep as the one for people living with HIV. We are implementing a contact investigation, but this is also inadequate and not really standardized across the different parts of the country. The resources are not completely available, so it's not consistently being implemented. So we do not reach all the children under 5 that we target to reach. And even among those that we reached, there are issues related to transport, issues related to caregivers being hesitant because the children are well. And it would be good to listen in from Kevin, really what are those key innovations, talk and implementing contact investigation. So we do have some hesitancy from caregivers, and we have some projects that are implementing community initiation of TPT, taking the services and trying to overcome the barrier of transport. We are also waiting for results, but for these projects, the health workers go at the first time of screening. If the child is identified, they move with weighing scales, initiate treatment, and the community health workers do the refills and the subsequent TPT screening. So we were hit by COVID-19, and this also impacted on community activity. So we see a drop in TPT initiation because contact investigation was suspended. And even now, we are having a restricted. Yes, thank you. Sorry, for the monitoring and evaluation, we have the indicator is coverage we have for under 5s, we also have for above 5, and PLA, people living with HIV, but our registers are able to capture the follow-up cascade, and we are able to pick those that have developed side effects, developed TB, and those that have completed treatment. So we are able to pick that information for all that are started on TPT.
So thank you, Maureen. That's the presentation from Ghana. So I must say, I think she's trying to respond to Steve. So for Zambia, we do have what we call the initiation in terms of targets, how many people we're initiating on TPT, and then we also follow through how many are completing the TB preventive therapy that is there. Then as a Ministry of Health, we've also set our own target. Remember, you have the UNAIDS 95-95 targets. For the people living with HIV, Ministry of Health Zambia has set a fourth 95. We want to make sure that 95% of the people living with HIV are on TPT. So it's one indicator that we're able to track. So we do have both the hard copy registers and the electronic register, and as well as our 2 codes, Smart Care, which is where we see our patients there. And this information is tracked almost weekly. We have a situation room where we discuss weekly on how many patients that are being put countrywide. It's fed from the districts in the province into national level weekly. So we're able to track this week. And it's one of the things that has made Zambia be able to sustain some of the gains it had made despite COVID because of this weekly discussion that is there. We heard from Ghana, Uganda, Zambia. Is the network good for us and from Tanzania, or we hear from another member country?
From Kenya?
Please go ahead.
Yeah, for Kenya, the regimen which we are using for the under 5, the HIV negative, is the 3RH. And for the HIV positive is isoniazid for 6 months. The challenges which we are facing is inadequate training of frontline healthcare workers. Due to this, the healthcare staffs are not aware of the new TPT recommendation and hence unaware that their roles and responsibility in the implementing of the latest guidelines, because we've just revised our guidelines to this regimen, which we are rolling out to the counties. Inadequate advocacy, communication, and social mobilization activity to create demand for TPT in the community. Also, the impact of COVID-19 pandemic has been felt on TB services, resulting to drop of TB cases being notified, and this has affected the provision of TPT in the household contact. Therefore, it's crucial to advocate and ensure TPT services are not sidelines, administer the crisis of adequate focus on attention to be given on TPT. So I will call my colleague, Dr. Owiti. I think he has more to add to that on the indicators of TPT and any other comment which he has.
Okay, so while we're waiting for the colleague from Kenya, Dr. Omiti, Grania has a poll to share, which you can quickly participate in. Okay. Please, we can take a few seconds and take the poll. So the poll is, what do you use for TPT? I've answered the question, so I can't see it on the screen.
I think we can, if the other colleague from Kenya is available to talk, he can maybe add while people are reviewing the poll. I think that should be possible. Thank you.
Please go ahead.
I do not see Philip Owiti online at the moment. Perhaps he has also connection problems. Is it okay, Kevin, if we invite another country while we wait for Philip to rejoin?
No problem. Yes, we can ask another member country to rejoin.
Evan, I can end the poll now, so we can, and I'll share the results. Just so everyone.
Yeah, please end the poll. Okay, so the poll results are interesting. So we are saying that about 15% of our member countries just use coverage as one of the indicators that they track. Others are looking at uptake, and others are looking at completion at 5%. And 65% of the member countries are using all three indicators. That's quite interesting. Okay, any other member country to give an answer? I have a question in the I have a comment in the chat that is coming from Brittany on our M&E plan. So the weekly M&E plan, we call it the TB situation room. So it's held every Thursday afternoon at 14 hours, where we discuss the previous week's performance. And we look at several indicators, our TPT initiation, our diagnosis, how many were bacteriologically confirmed, studies. It says that about 60,000 people suffer from TB every year. For the last 3 years, we've been having, for the last, I think, 4 or 5 years, we don't meet more than 55,000 cases. So we are very ambitious. Last year we did 40,000. Hoping this year we do 50,000. So we have a target of, each province is given a target to meet, so that we meet that 55,000 at the end of the year. So the situation room analyzes all that data, and the M&E team compiles it and feeds it into him and shares nice graphical presentations every Thursday afternoon from 14 to 15. Okay. I think we can get, we have a few minutes to go. We're just under 5 minutes to go. Any other quick bending? Does it? Okay. Dr. Dube, please go ahead.
Thank you, Dr. Zimba. Just a correction, it's Mr. Dube. I'm Simba Dube from Zimbabwe, National TB Control Program. I just thought I would share some of our experiences around 3HP implementation. So just to say, to date we've initiated close to 20,000 patients on 3HP, and this is both with a single dose of rifampicin and with the fixed dose combination. One of our keys to our success in terms of implementation of 3HP, rapid implementation has been that actually we don't have much in terms of the commodity due to issues around global supply and the like. So that has allowed us to be able to target our training together with the supplies. So to say, each time we're rolling out, we select particular sites, and as we distribute the medicines to them, we then also provide a site level facility training. And we've done that by trying to train everyone on TPT at the facility, right from the guard at the hospital to the clinicians. Of course, what's sort of delaying us in terms of getting as far in terms of the numbers that we would want is the availability of the product from on a global scale. So I thought I'll just share that with you colleagues. Thank you.
So thank you very much. So there's a comment that about our situation room. So it's all facility staff. We're like the focal point person for the TB in the facilities and the province, sit through it. And even high leadership at the province, the public health specialists do sit in. And the meeting is actually chaired by the national TB leprosy manager. He's one who chairs the meeting with the M&D team at MOH that does that. So the provinces have weekly, bi-weekly, where they analyze, each province analyzes its own data before feeding it into the national meeting that is there. And in the interest of time, I think we are running out of time. I do hope this discussion was very helpful and has highlighted the country WHO guidance on TPT for children and adolescents, including the best practices that have effectively contributed to the programmatic TPT response for implementing and scaling up TPT among children, adolescents, not forgetting the children living with HIV and the childhood TB contacts in routine programmatic settings. I would like to welcome Dr. Brittany Moore and lead for the pediatric TB for the United States Centers of Disease Control and Prevention Global Health TB Division to say a few words.
Thank you, Dr. Zimba and Dr. Glodlo as well for chairing today's session. I'd like to also thank today's speakers for sharing your expertise, and to all the participants too for joining what has been an engaging and thoughtful discussion. Thank you for sharing country experiences during the Q&A. These experiences and best practices for scaling up TPT among children and adolescents will contribute to strengthening and building the national child and adolescent TB response within our member countries. As Grania had mentioned earlier, the WHO call to action on TB prevention underscores the importance of overcoming existing barriers to providing TPT to children and adolescents, including, of course, CLHIV and child contacts. We hope some of the information shared today can inform this work in your countries. We're interested in exploring more, for example, the TB situation room in Zambia and other innovations for how to push these priorities forward. We will continue using our platform at the COE to share your best practices for implementing TPT and other critical TB services among children and adolescents as we work together to achieve the ambitious targets outlined at the UNHLM. All of you will receive a follow-up email with a survey on the session. We would really appreciate it if you could complete the survey and provide your feedback on this webinar to enable us to continue improving and refining our COE webinar series. We will also share with you additional reading materials and a link to view the recording of today's webinar. On behalf of the CDC, our partners at the Union, our presenters, thank you for joining and enjoy the rest of your day.
Thank you. Bye-bye.
Thanks, everyone. That was excellent. Thank you.
Thank you, everybody.
Thank you.
Thank you.
Bye-bye.
Have a nice rest of the day.
Thank you. Thank you. Bye.
Bye.
Bye.